Good morning, everybody. So, welcome to the first session of the cardiology track. It is an honor to have so many participants in here, and I hope you will continue attending also the cardiology sessions. We are chairing the session today. My name is Diana Paez. I'm the nuclear medicine physician and head of the nuclear medicine and diagnostic imaging section at the International Atomic Energy Agency.
My name is Sue O'Malley. I don't have any imminent qualifications like my co-presenter, but I work in the workforce as a cardiologist and nuclear medicine physician, passionate, and it's great to see people who want to come and learn, so looking forward to this session as well.
Good. So the first session is about doing nuclear cardiology right. And the first speaker will be Professor Joao Vitola. Joao is a cardiologist and nuclear medicine physician from Curitiba, Brazil. He has extensive experience in the field of nuclear cardiology with many publications, and I'm very proud to say that he is one of the IAEA experts in the field of cardiology. He has been going around the world promoting the appropriate use of nuclear cardiology, the safety use, and how to do the things right. So today, Joao will present the INCAPS, which he will explain what the acronym mean.
Good morning, everyone. Thank you so much to the organizing committee, especially my good friend Nathan, for the kind invitation to come back to Australia. It's really a lovely country. Love to be here among friends. So my job this morning is to talk about the INCAPS study and what kind of implications that has to the practice of nuclear cardiology. So INCAPS was an international cross-sectional study of nuclear cardiology utilization, dosimetry, and protocols that was conducted and coordinated by the IAEA. And of course, many of you are familiar with the IAEA, which has a headquarters in Vienna. It's the International Atomic Energy Agency. An executive committee was formed with regional coordinators for this study around the globe, with an investigator group of members from 65 countries. This project was initiated in 2012 and was performed with the assistance of many professional societies. It led to this main publication in 2015, and I'll go through this data with you, but besides this main publication, we had approximately 10 other papers coming out of this. And each of these papers focused on a different aspect, a regional aspect perhaps. There were papers written with data from Africa, from Europe, from Latin America, several different parts of the world, the gender differences, etc. So all these were publications that came out of this project. But before I get into the details of the INCAPS, I would like to take this opportunity and briefly tell you a little bit about the IAEA, which those of you who were at the plenary session heard from Dr. Diana Paez already, but I'll just mention briefly. The IAEA has been a tremendous help to the nuclear medicine community around the world. It's part of the United Nations. There are 171 member states. There are three main areas of work on the IAEA: safeguarding and verification, nuclear safety and security, and nuclear science and application. And this is where nuclear medicine fits in. There are areas of support. Research is one of them, such as the INCAPS study. Also technical cooperation. In the past approximately 10 years, there were, through technical cooperation programs, there were $200 million granted to projects in human health, which was of tremendous help to the development of nuclear medicine throughout the world, especially to the developing countries. And these are the countries that have technical cooperation projects with the IAEA, mainly in Africa, Latin America, some Middle East, South Asia, Eastern Europe, and these parts of the world. Education is a big part of what the support the IAEA provides. And I invite you all to visit this website, which is a great source of scientific information. There are approximately 5,000 visitors every month, and the cardiovascular session is one of the most popular, with many clinical cases, teaching files, and protocols, appropriate use criteria, many very important scientific informations. And also you can find scientific publications such as this, all written from the groups that gather together in Vienna. And there are scientific meetings every 2 or 3 years called Integrated Medical Imaging Cardiovascular Disease. The last one was in 2016. And it involves not only nuclear, but other kinds of complementary modalities in cardiac imaging. So let's get into the INCAPS in the next few minutes. When we think about INCAPS, we have to think about the risk of testing a patient and the harm due to radiation and what kind of scientific evidence we have of that, versus the risk of not testing our patient due to the risk of cardiovascular disease mortality, which is still the #1 killer in the world in most countries. And when we think about harm versus use, and this is in fact the basis of the INCAPS lessons, we have to think about justification. Justification. Appropriate use criteria relates to that. Any test that's ordered has to be justified. The best way to avoid radiation to a patient is to avoid a patient of undergoing an unnecessary study. When we think about reducing radiation to the patient, we have to think about optimization, doing the right protocol for the right patient, using the right tracer at the right dose, using the right protocol, and always keeping in mind the ALARA principle. You're all familiar with the ALARA principle, as low as reasonably achievable. What is the risk that this patient has in terms of being exposed to radiation in comparison to the risk of this patient having a cardiac death? It's obvious that when a test is well indicated, such as it was in this case, the risk of testing is much negligible in relation to the risk of not testing. Why was the INCAPS justified? Because there are many nuclear studies done throughout the world, between 15 and 20 million myocardial perfusion studies performed, approximately half of them in North America. There are very heterogeneous protocols done throughout the world. Some use high radiation doses, some low radiation doses. Before this, no previous study had characterized nuclear cardiology practice at the global level. And the IAEA identified that knowledge of worldwide protocols was needed, as well as learning about the practices and dosimetry, and identified this as an important priority. So in March of 2013, the IAEA contacted potential sites and requested voluntarily their participation. During a week of work in these labs in these 65 different countries, information was provided to the agency regarding lab demographics, regarding the protocols, and what kind of nuclear cardiology was being practiced in these different parts of the world. The methodology involved radiation exposure quantified using effective dose, considering what has been published by ASNEC guidelines as an intention to have at least or less than 9 millisievert or of effective dose to the patient. 8 radiation-related best practice were identified by an expert committee at the IAEA, and also some lab quality index were determined and considered best practices. The main 8 best practices that were identified and discussed were to avoid thallium stress, especially in patients of younger age than 70 years old. Avoid dual isotope, just because of the radiation-related and the long half-life related thallium studies. Avoid injecting too much technetium, and too much technetium meaning injected doses of 36 millicuries or above, or mean effective dose of 50 millisievert when 2 technetium injections were part of the protocol. Avoid too much thallium, especially doses that exceeded 3.5 millicuries for stress. It was considered a good practice perform stress-only image in at least 1 patient during that week. Use camera-based dose reduction strategy, including attenuation correction, including hardware in terms of detector, high technology hardware such as CZT or PET-CT, and importantly software, which is widely available today, resolution recovery. Importantly, base the dosing on patient's weight, which was, as we will see, not so frequently done throughout the world, in avoiding appropriate dosing that could lead to a shine-through, meaning not doing the appropriate study in terms of the dose injected at rest compared to the dose injected at stress. These were the main results. And as you can see in this graph, the wide range of effective dose that were found, going from very small doses in some parts of the world to very high doses in other parts of the world. Europe was the one that had the lowest effective dose. Latin America and Asia were the places in the world with the highest effective dose. And we explain why those were the cases. It was identified that avoiding thallium injection, avoiding dual isotope, and avoiding injecting too much technetium were some of the most effective ways to reduce radiation to the patient. And I'll go through the Latin America data, because Latin America didn't look too good in this project. And what were the opportunities for improvement that we identify that could serve as lessons not only for Latin America but also for other parts of the world? Interestingly, there was a correlation, an inverse correlation between the volume of patients seen in a laboratory compared to effective dose. I'm using as an example here laboratory number 6, which is our laboratory in Brazil. We have a very high volume of patients, and usually laboratories that have high volume, they tend to follow guidelines. They tend to follow protocols, strict protocols. And as you can see, our mean effective dose in this project was 8.4. So exactly what's recommended by ASNEC, below 9 millisievert. And we identified that adjusting the dose by the patient weight and using software to limit the dose, and whenever possible, doing a 2-day protocol were some of the most effective ways to reduce radiation to the dose to the patient. When we look at Asia, for example, avoiding thallium would be a very good way to reduce radiation dose to patients in Asia. And it's understood that since INCAPS was published, there has been a trend towards using less thallium in Asia, which we think this is a very good thing. And in addition to that, weight-based in dose was also something that could be improved in Asia. In Latin America, simply injecting less technetium, and injecting technetium based on the patient weight. Very similar to North America, which actually didn't look very good in this study either. And Oceania, weight-based dosing for technetium would be one way to improve radiation exposure to the patient. So in summary, there were marked worldwide variation in terms of radiation, going from as low as 2 millisievert to as high as 22 millisievert. And we certainly identify very good opportunities, and some of these opportunities are very simple to implement. And we are very happy to notice that in the past few years, there have been major advances in terms of reducing radiation dose to the patients. And we are about to start at the IAEA a project to measure effectively how significant these reductions have been worldwide. Thank you so much for your attention, and I thank all those who participated on this project.
Vitola, for the excellent presentation. Any questions in the audience? Yes, please. 1 second. There is somebody already in the mic.
Sorry. Nakajima from Japan. We are sometimes discussing about the INCAPS study also in Japan, because in Japan the use of thallium-201 is more than 50%.
Yes.
And it has not been changed. It's a little bit surprise even for us. But probably so image quality is better, and the cardiologists prefer to use thallium-201 still now. And other part is injection 2 times. 2 injections are necessary for doctors. So do you have any comments? We also try to change it. But,
I think one very important aspect is to look at the broad picture, and be very careful when we talk on this subject in order not to scare the population. Okay? I've been to Japan a few times, and I understand that there's tremendous, in not only Japan, some other places in Asia, tremendous scare about radiation.
yes.
And we cannot forget that the #1 killer is cardiovascular disease. And if our patients are afraid of having a nuclear study that potentially can be life-saving, that's a very bad thing. Thallium is not the devil. Okay? We have new technologies today with CZT that we can use very small doses of thallium. Okay? And if this is what you have at hand, and your patient has a good indication, an appropriate indication for a study, go for it. Use the best, optimize your protocol. Optimize your protocol. Don't use very high doses. Don't go on screening heart disease on 20 years old. But if your patient is 70 years old and need a thallium scan, and especially if you have a solid state detector camera and you can optimize your protocol, go ahead and do it. So this is not the issue to make thallium the devil. The issue is to discuss how can we improve things? How can we do a better job?
Okay.
Thank
we
you.
have many ways to reduce it. Thank you.
So the last question before going to the next section, please.
Stephen Stowers from New Zealand.
Go New Zealand. Kia ora. So, job, excellent presentation. I presented this data to my radiology nuclear medicine colleagues, and they're saying, what evidence is there that weight-based dosing affects patient outcome? and they're concerned that reducing the dose will decrease image count
No.
and image resolution.
Yeah.
Do you have any mortality, morbidity?
Yeah, Steve, you know, we both start practicing nuclear cardiology when we were using
Too much.
you know, too much thallium, and the software we had at those times and the kind of hardware, and it was really a miracle that we could take diagnostic information from those kind of images that we were acquired in the early 1990s. I think technology has improved tremendously. And today, indeed, we can use much lower doses and get beautiful images, you know? And one of the important aspects, you don't necessarily have to be able to afford a PET-CT or a CZT camera, but softwares are widely available, and resolution recovery tremendously help us to be able to use low doses adjusted to the patient's weight. And one of the things that we notice in many of these countries were fixed dose. I inject 10 millicuries for rest and 30 millicuries for stress. Who said that we should do that? For a 60 kilo elderly lady, the same protocol for a 150 kilo 40-year-old man. So these are the things that I think INCAPS is helping us to think about when we think about weight-based dosing. We can do good quality work injecting less dose to the patient.
So thank you, Joao. I just want to add a very brief comment, is that based on the results of the INCAPS, the International Atomic Energy Agency developed an e-learning module that includes the 8 best practices. You can look for the module at the Human Health Campus. The address is www.humanhealth.iaeea.org. And in the nuclear medicine cardiology component, you will find the 8 best practices, and you can see some strategies to actually reduce the exposure to patients. Thank you, Joao. So,
thank you very much. That was a really erudite presentation and of great practical value too. Our next speaker is going to be Professor Prem Soman. I've met Professor Soman for the first time today, but he's the president of the American Nuclear Cardiology Society, so I think it's going to be another very good presentation. And I believe he's also representing from the University of Pittsburgh. So looking forward to your presentation. Thank you so much.
Thank you very much. Thank you. Good morning, everybody. I bring you greetings from the American Society of Nuclear Cardiology, and I want to thank my friend Nathan and the organizers for inviting me here. I feel very privileged to be here. This is my first visit to Australia, and I am overwhelmed by the beauty of your country and the friendliness of your people. So thank you very much. Now, when I was putting this talk together, it occurred to me that AUC is sort of uniquely an American phenomenon. And I know a lot of people use AUC, but it has not been formally adopted in other countries. And so I changed my talk a little bit. It's more articulating the philosophy behind the AUC and one or two examples of how we use it. And sure enough, if you look at Wikipedia, the first sentence says that they deal primarily with the United States and do not represent a worldwide view of the subject, and this is very true. Now, in the US, as you know, we practice medicine mostly on a fee-for-service paradigm. And in the late 1990s and 2000s, it became very clear that imaging, not just cardiological imaging, but imaging for all of medicine was increasing at a huge percentage. And so one of the reasons the AUC were created was to create a guideline for physicians to refer patients appropriately. Now, you know that in 2015, we made a law that now mandates an increasing percentage of the reimbursement for American physicians be based on quality and not quantity. And so we are finally catching up to the rest of the world in practicing medicine in what should be the right philosophy. So the definition of appropriate use, and this is the Institute of Medicine, says that a test or a therapeutic procedure is appropriate if the expected benefits, and this might be a survival benefit or any health outcome benefit, they exceed the expected negative consequences of testing. And negative consequences are not just side effects of stress testing or radiation, but also things like how many downstream tests you perform based on a single test. So if I were to report every small perfusion abnormality in a perfusion scan as abnormal, and that resulted in a lot of coronary angiograms, that is a negative consequence. So this is also taken into account in this definition. And unlike the guidelines, unlike the clinical practice guidelines, when scientific evidence is available to guide the performance of a test, that's given priority. But as you know, in many areas of medicine, what we do is not always supported by class 1 evidence. And in these situations, the AUC will use collective expert judgment as an alternative mechanism to make decisions. Now, the AUC methodology, and this is the methodology that the American College of Cardiology follows, is very complex. And so in step 1, they convene a writing panel of experts that develops a group of typical clinical scenarios after review of the literature and guidelines. So this panel consists of about 5 people. It takes about 2 years to develop a set of AUC. In step 2, there is a rating panel, and note that this rating panel, which consists of about 13 to 15 people, it incorporates imagers, clinical, and health policy experts. So a broad base of experts. And I've been to some of these. It gets very animated, and it gets very exciting, briefly reminiscent of the British Parliament at times. And they use the Delphi method. So there's iterative scoring. So each person scores each criteria individually. Then there's a face-to-face meeting where people present the evidence, and there's a rescoring. And then there's a final independent scoring that results in the final rating. And you have different classes of rating. So anything that's rated in the highest tertile is an appropriate use, ranging from 7 to 9, and then you have maybe appropriate and inappropriate. And once the rating is done and the paper is written, a completely different set of reviewers actually looks at the paper, primarily to make sure that these ratings are not discordant in a large manner with existing guidelines. So this is the methodology. Now, the first appropriate use criteria actually were developed for nuclear cardiology in 2015, and the initial appropriate use criteria were all unimodality. So you had AUC for nuclear, you had AUC for echo, you had AUC for cath, so on and so forth. But in 2013, we changed tack a little bit and developed these multimodality AUC. So now the AUC are not based on individual imaging modalities, but rather on clinical situations or disease mechanisms. So here, for example, is the first multimodality AUC developed for the detection and risk assessment of stable ischemic heart disease. And here you see in this table, you have listed here all the potential imaging modalities that can be applied for these various clinical scenarios, and they're all rated. Really important to note that this rating is not rank order scoring, so it doesn't tell you, for example, that a CT angiography is better than echo or echo is better than nuclear. It just lists all the modalities that may be appropriate to perform in a particular clinical situation. Now, all the subsequent AUCs are disease-based and multimodality, and the most recent publication was for the multimodality use in valvular heart disease. Now, the other evolution that occurred in the AUC was that when they were developed, it was very clear that they were not intended to adjudicate individual cases. So you and I as clinicians have the final authority on saying what test to do for what particular patient. But they are intended rather to define patterns of care. So if you look at my referral pattern in a year, and let's say that 50% of my referrals of a perfusion imaging in low-risk preoperative evaluation, then you know that there's some scope for education there. So they're not intended to actually adjudicate individual cases, even though a lot of payers and regulatory authorities will sometimes do that. And with that in mind, the nomenclature was changed. The original ratings were classified as appropriate, uncertain, or inappropriate, very definitive terminology. And so in 2000, with that view in mind, the names were changed. The uncertain became maybe appropriate, and inappropriate was changed to rarely appropriate. The sentiment being that there are occasional situations where a patient may not fit definitively into an AUC category. So let's take an example. It's a real-life patient, and I'll go through the process of applying AUC. So here's a 45-year-old man who requests a cardiac assessment. So he's able to exercise, got good functional capacity without angina or other symptoms. He has a little bit of dyslipidemia, and he has hypertension. And what worried him was the fact that his father had a fatal MI at 38, a brother had an MI at 40, sister with CABG at 45, and his ECG and blood pressure are normal. So what do you do for this patient? So you have a choice of stress echocardiography, stress MPI, you could do a calcium score, you could do a coronary angiogram, or you could simply do an exercise ECG. Now, I didn't put CMR or PET here because we can routinely perform either of those with exercise. And in patients who can exercise, we generally prefer exercise stress testing as the stress modality of choice. So the clinical scenario here and the relevant clinical questions are as follows. The scenario, as this is a gentleman who's completely asymptomatic and he has good functional capacity. Okay, this is really important to remember. The clinical question here is, because of his strikingly strong family history, is there subclinical coronary artery disease here? And more importantly, because of his family history, is he at high risk for MI or death? That's the question. And the decisions that one needs to make is, do you just give him primary prevention, or is there scope for secondary prevention here? I mean, I would go in this particular patient, although you rarely have an indication to revascularize an asymptomatic patient. The question that you're all asking here is, he has such a strong family history of coronary artery disease, is there any reason to do an angiogram and revascularize this asymptomatic patient? So in asymptomatic people, so in people who have symptoms, we classify the pretest probability of coronary artery disease. In patients who are asymptomatic, we calculate a global risk. And the original risk stratification approach was to use the Framingham risk score, or the ATP3, and based on the criteria that I've listed here, this person has a 12% chance of either developing coronary artery disease or having an adverse event related to coronary artery disease over the next 10 years. So that's sort of moderate risk. But as you know, we've all and important to remember that family history of coronary artery disease does not count. Now, we've all moved to the pooled cohort risk stratification tool, and based on that, his risk score is 6.7% over the next 10 years. So there's a slight disparity between the ATP3 risk stratification methodology, which is what we use in the guidelines, but then the new pool cohort risk calculator, which is the new approach recommended by AH and ACC. And here again, the family history of CAD does not count. Okay, and there's a reason. There's a reason for that. Now, if you look at the multimodality AUC, and I've clubbed here all types of functional stress testing, in an asymptomatic patient by CHD risk, you can see here that no test gets a completely outright appropriate indication. And this is because the patient is completely asymptomatic. Now, if the global risk score is low, there's really no reason to test. If it's intermediate, it may be appropriate in patients whose ECG is not interpretable at baseline, if they have more than 1 millimeter ST depression, LVH, or pre-excitation, anything that precludes the identification of ischemia, you may do a functional test. And even in high-risk patients, the indication is maybe appropriate.
So why do we have this sort of a recommendation? So there are several problems with functional testing in screening asymptomatic patients. One is they generally have a very low pretest probability of obstructive disease. Now, if you look at the original risk stratification methodology, Diamond and Forrester, the Maurice system, and then the gender system that the Europeans use. And if you look at chi-square values of different models, when you add on family history to the traditional risk stratification parameters that we use, there is very little additive value. Despite our clinical intuition, adding family history doesn't improve the model all that much. So in patients with no symptoms, there's usually a low pretest probability, and an abnormal test is likely to be false positive. It's more likely to be false positive than true positive. So if you take a young woman with atypical chest pain and you do a perfusion scan and you see an anterior perfusion abnormality, it is more likely to be a breast attenuation artifact than a true perfusion abnormality. And remember that the stress test only detects flow-limiting disease, but mild plaques can cause cardiac events. So when you look at only functional testing without looking at subclinical atherosclerosis, and you say that the stress test is normal, sometimes it provides a false reassurance to the patient. You say everything is normal, and we forget about intensive risk factor modification. So this is why in the AUC at least, testing patients with very low risk and with patients who are completely asymptomatic is generally not recommended. Now, if you look at the distribution of appropriateness testing in the US, and this is large data from United Healthcare, you can see that if you look at this chunk of patients where testing is inappropriate, which is about 13%, a large majority of that is actually testing low-risk asymptomatic patients. So this is really important. This is a group where education is necessary to reduce the percentage of inappropriate testing. And the second large group that I alluded to briefly is pre-op evaluation in patients with good functional capacity and low-risk surgery. We still test a lot in this patient group. Now, here I have listed not the individual AUC, but if you look at what is appropriate in this asymptomatic intermediate risk patient, the functional tests are not recommended. Calcium score and exercise ECG may be appropriate. So this is how the AUC play out for this particular scenario. So in this patient, he had a calcium score, and as you can see here, his total calcium score was 438. It's more than the 90th percentile for his age. And now, if you go back, stress testing becomes appropriate, because an appropriate indication for testing asymptomatic patients is if you happen to have a calcium score and that's more than 100, right? So now this patient underwent a stress test. This was completely normal, and you know what we did was intense risk factor modification. Now, do the AUC work? Now, in our guidelines and actually in the new law that's written and passed by Congress, an increasing proportion of physician reimbursement is now based on quality. And part of the quality is applying appropriate use criteria for testing. And so there's a lot of interest in whether this works. And this is from Bob Hendel and Rami Dookie, and I think this is a landmark publication in the field of AUC. And this looks at 1,500 consecutive community-based MPI, not big academic centers, with patients followed up for about 2 years. And what you see here is that if you take patients who are selected for a test based on appropriate indications, the test is very good at deciding who's likely to have an adverse event and who's not. The prognostic utility of the test is maximum in these patients, whereas if you take patients who are tested for rarely appropriate indications, then the discriminatory ability of the test is much lower. And a normal test doesn't always indicate a benign prognosis, but more importantly, an abnormal test doesn't indicate an adverse prognosis. So what's most important here is to remember that performance of the test itself is not optimal when the therapy is chosen inappropriately. So I will stop here, but before I leave, I just want to invite you all to the annual meeting of the American Society of Nuclear Cardiology. This is going to be held in San Francisco, and I was telling Sue that if there is a trip from Australia to the US that is easy, it's this one. So please come and join us for this.
Very much. I realise that you probably had some more to say, but I appreciate your keeping to time. I'd like to introduce our third speaker. You realise that there are 8 cardiology sessions, so it's really going to be a huge fest of information over the next few days. So our third speaker is Dr. Paula Abadouche. She has a training in Argentina as a cardiologist, but she's also now migrated to Adelaide where she practices nuclear cardiology. And it's great to have another lady speaker. So without ado, I'd like to introduce Paula. Thank you very much.
Well, thanks very much for the introduction, and it's a real honour for me to be here presenting today. I've been asked to talk about what's best for women in 2018, and I think this is a great topic. It's extremely important, and I will tell you shortly why. The number one killer in Australia, in women all over the world, is cardiovascular disease. It kills 1 in 3 women worldwide and 1 in 2 over 50 years of age. Heart disease claims 24 female lives every day in Australia. That is 1 female an hour. Heart disease kills more than 3 times as many women as breast cancer and accounts for 1 in 8 deaths in premature deaths in women. And very importantly, what we have seen in the last 3 decades, it's a very significant decrease in mortality, in mortality rates, mostly in men, but women do not follow the same trend. So we see that there is a significant knowledge gap about cardiovascular disease in females. Let me show you this graph. The curve on top is about males and females in the bottom, and they're divided by age, and it depicts the mortality in the last 3 decades. The lowest curve are elderly patients over 65 years of age, and you can pretty much say that even though mortality in women is less than males, they kind of follow the same trend. But look at the top curve. Males on the top, women on the bottom. There's been no improvement despite statins, aspirin, improvements in intervention. Women still have not improved mortality in the last 30 years. Flat curve. So we must be doing something not quite right. So this is Donald Rumsfeld, Secretary of Defense of the United States, and he said this in a press conference. He said, as we know, there are known knowns. There are things we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also the unknown unknowns, the ones we don't know, we don't know. Okay. Exactly. Well, he won a prize for this called Foot in Mouth. So let's start with the known knowns. There are 6 related differences in the prevalence, presentation, management, and outcomes of cardiovascular disease. And this includes largely the presence of traditional and non-traditional risk factors, the more frequent atypical presentations in females, significant delays in recognition, diagnosis and health care seeking behaviour, lower intensity of care, and very importantly, the evidence in females is very deficient because we tend to extrapolate the evidence in males, in trials conducted predominantly in males. So I'm going to talk a little bit about traditional and non-traditional risk factors. The presence of hypertension, diabetes, dyslipidemia, smoking and physical inactivity, as well as obesity. In females, these risk factors either have a higher weight, a more significant weight, or higher prevalence than in males. For example, hypertension is more prevalent in females over 60 years of age than males. Diabetes confers a higher risk of stroke and heart attack than in the counterpart males, and confers 3 times mortality compared with non-diabetic females. Dyslipidemia with the metabolic syndrome and hypertriglyceridemia is a more significant risk factor in females and males. Smoking confers 25% more risk to females than males, believe it or not. Physical inactivity and obesity both more prevalent in women. To this, we have to add on the non-traditional risk factors. The presence of hypertensive disorders of pregnancy, higher risk of ischemic heart disease and stroke. Preterm delivery, bad news for the mum and for the fetus in terms of cardiovascular disease. Gestational diabetes with increased diabetes development down the track. The treatments for breast cancer, cardiotoxic, more ischemic heart disease, radiation causes valvular heart disease, accelerates atherosclerosis with earlier development of ischemic heart disease and so on. Autoimmune disease, which is much more prevalent in females than males, is also a risk factor. And the presence of depression, which is also a heavier risk factor for females than males. So, in a nutshell, what happens with ischemic heart disease in women? Symptoms are more atypical and there's different pathology. There's delays in seeking help. Staff take longer to realize a diagnosis. They more often have challenging techniques. Once they are in the cath lab, we see smaller caliber arteries, which are harder to revascularize, more diffuse disease, they are less suitable for PCI or CABG. We see much less obstructive coronary disease than in the counterpart males, more microvascular dysfunction, more spasm, more spontaneous coronary artery dissection, more higher rates of bleeding post-cath. They're more likely to have a complicated journey overall and ultimately worse outcomes. So in terms of treatment, women with stable angina receive less aspirin than men. There's delays in commencing aspirin, ACE inhibitors, beta blockers, ARBs, aldosterone inhibitors and statins in women. We undergo less procedures and less revascularization, and there's poorer outcomes and lower quality of life in women than men. So let's move on to the 9 unknowns. So what are the underlying causes of such complex presentations and worse outcomes? Although there's been some light in recent years, there's still a lot of speculation. How to best apply investigation tools for a more accurate diagnosis, and how to best treat women with cardiovascular disease. So when we exercise a patient, with normal arteries, we know that we can increase the flow down the coronary artery to supply the increased amount of the myocardium for about 2 or 3 times. But as a stenosis progresses to about 70% or plus, that ability is lost. And then we can see differences in perfusion. And that's the base of performing perfusion scans or stress echocardiograms, is to see decreased flow or regional wall motion abnormalities as a response. But what happens at this side of the curve? Less than 50% stenosis. Is it really benign? Because we would very likely miss it if we kept investigating women with the flow-limiting tests. The WISE study, which followed nearly 1,000 women who underwent coronary angiography, demonstrated that 31% of the cardiovascular deaths 10 years after the cath was due to where women that did not have obstructive coronary artery disease. So this is to show that it is very likely that non-obstructive coronary artery disease is not benign. So you're all very likely familiar with this graph. When we exercise a patient and the rate pressure product increases, we look at flow heterogeneity as an early change, regional wall motion abnormalities, and ultimately ischemic AC depression and angina, which I'm going to add on 2 more parameters: the presence of endothelial and microvascular dysfunction earlier than that, and subclinical coronary artery disease. With exercise stress tests, we look at angina and ischemic AC depression, which are pretty late events in the ischemic cascade. With stress echo and stress MRI, we look at regional wall motion abnormalities, and with perfusion scans, SPECT, we look at flow heterogeneity. However, all these tests look at the critical stenosis diagnostic approach, okay, so flow-limiting stenosis. But in my view, the risk is not just that. The risk also includes and starts early, okay, and this seems to be particularly important in females. So when trying to answer those questions, which modalities can we apply to try and make a change that can visualize plaque? I came up with CT, CA, PET perfusion, imaging, and MRA. So part of the mystery lies in the plaque. I'll take you to this article where they analysed with OCT, is optical coherence tomography, and compare the consistency of the plaque in women's and males. And they analysed non-culprit plaques and also acute coronary syndromes. And what they saw is that in the non-culprit plaques, there was a higher prevalence of plaque erosion in women as opposed to plaque rupture, a smaller lipid arc, less cholesterol crystals, less calcification. And when there was thin cap fibroatheroma, which is what occurs mostly in males, in females, the disease was diffuse rather than clustered proximally. In acute coronary syndrome, something very similar happens. There is more plaque erosion than plaque rupture. The plaques in females are more fibrous, and there's not so much significant positive remodeling as seen in males. There's also a lower plaque burden compared to the counterpart males. So I'm going to take you to a clinical case very quickly. 39-year-old female, only risk factors lupus. She presents with an acute coronary syndrome, and she had no other risk factors. So she underwent coronary angiography, and I'm going to show you what she's got there. Sorry. So, went to the previous slide, sorry. So what she's got there, this is the LAD, this is a circumflex, and she's got an acutely blocked obtuse marginal artery. They aspirated the thrombus with an export catheter, and this is the angiogram immediately after thrombus aspiration. It is a normal artery. Once the clot is gone, there is no underlying plaque. They applied this technology called OCT, which instead of using ultrasound, it uses light. And what you can see there is the 3 layers of the coronary artery wall: endothelium, the muscular layer, and the adventasia. And this is they wanted to clarify that segment, and the OCT was entirely normal. Okay, so that's an artifact caused by the wire. Okay, and the little holes that you saw before were the branches that just came out of the artery. So it was an underlying completely normal artery. There was no significant plaque. And they sent this for histology, and what they saw is that what they had aspirated was actually white thrombus. Okay, it's rich in fibrin and not so much in red cells, as opposed to the classic aspiration of clot in broken plaques, which is made of mostly red cells. So this forms in a chronic state, and this forms acutely. So which non-invasive modalities can we apply that can characterize the atherosclerotic plaque, detect non-obstructive coronary disease, and serve as a prognostication tool? Well, I came with CTCA, PET perfusion scan, and MRA as attractive modalities. With CTCA, we know it's a non-invasive option for coronary angiography and plaque characterization. With contemporary technology that has improved spatial and temporal resolution, we can acquire really good images of the heart whilst in motion. It has an excellent accuracy compared with IVUS, and it's an excellent tool for prognostication. And I'm going to briefly talk about the Concurrent registry, which, although it was published in 2011, I think it's very relevant to this because it included 25,000 patients that were referred for CT in the setting of investigation of chest pain or pre-op assessment. And what they could see, and this is a multi-center study, and what they could see here is that when the coronaries were normal with no significant plaque, the survival was excellent. With obstructive plaque not so good, with obstructive plaque not so good, but with non-obstructive plaque, they also saw increased mortality. So just as a generalization, non-obstructive plaque doubled the mortality, and obstructive plaque doubled the mortality from the non-obstructive plaque. And also what they saw is that the more vessels involved with disease, the worse the prognosis. They also analysed females compared to males, and what they saw is that the presence of 3-vessel disease on left main had much worse prognosis in females than the counterpart males, and also the presence of non-obstructive disease, the amount of plaques per vessel when non-obstructive was more prognostic in women than in males. And in that subset of patients that had non-obstructive disease, the prognosis worsened linearly with a calcium score. The advantages of CTCA is minimally invasive, not terribly costly. You can visualize non-cardiac structures and diagnose PEs, pleural effusions, pericardial effusions, sarcoid, etc. It's widely available. You can measure calcium scoring and also some functional information. The limitations, you need a pretty steady heart rate, about 60. If you have an irregular rhythm, that makes images much more complicated to obtain. You need to sustain a breath hold for more than 5 seconds. And if there are stents or severe calcifications, then there can be artifacts, and little arteries of less than 1.5 millimeters diameters cannot be visualized properly. With the latest type of scanners and with newer acquisition modes that are used to reduce the dose, we can see that we can reduce the mean effective radiation dose from 18 millisieverts originally to 10 millisieverts with tube current modulation and 3 millisieverts with prospective triggering. So very low doses of radiation. Moving on to PET MPI, I'm going to talk very little about this, but it's mostly, for most of us, it's in the sphere of the dreams. But I think that this is perhaps what we should be doing in the next few years. This is the future. PET perfusion imaging in women is a maturing imaging modality. It has very good diagnostic accuracy, low radiation exposure because the radiotracers are very short-lived, and we have the ability to quantify myocardial blood flow and coronary flow reserve. So what are these parameters? And I'm very briefly going to go through them. Coronary blood flow and flow reserve, they're a combined measure of disease in the large coronary arteries and also in small coronary arteries, so it's very attractive in women. They show the hemodynamic effects of epicardial disease, diffuse atherosclerosis, vessel remodeling, and microvascular dysfunction on myocardial perfusion, and definitely has a prognostic value. The flow reserve is the ratio of hyperemic to rest myocardial blood flow, and a value less than 2 is suggestive of vascular dysfunction. So I'm going to show you a couple of studies just simply to show that this has prognostic significance. In this particular study, they're early studies though, they published about 2011. This group by Dr. Fukujima showed that if you did not have a perfusion defect, you did very well. But with significant perfusion defects, obviously the mortality at 3 years was significant. The same was reproduced with low myocardial blood flow, and flow reserve again was a prognostic parameter. Now, if you take the normal perfusion scans, you see that at least flow reserve still has prognostic significance. So. And again, we see this in another study, again, early study, and again, single center, published in 2011, where you can see that patients that had no perfusion defects and a normal coronary flow reserve did very well. At the other extreme, patients with significant perfusion defects and low flow reserve did poorly. And in patients with normal perfusion, but reduced myocardial flow reserve, they do poorly. And you can see in this curve that it has additive value to perfusion only. And maybe I'm going to finish here with this last graph. This was published in Circulation last year. This is a group of about 300 patients that had PET perfusion imaging and were referred for coronary angiography. And they had quantitative measures done in PET perfusion. And we can see that for the female group, at lower coronary flow reserve values, women do a lot worse than men. So it does sound like that coronary flow reserve is actually an interesting parameter to measure in women. Okay, it tells us about large coronary disease, but also small coronary artery disease. It tells us about diffuse coronary artery disease, and is certainly prognostic. I'm going to skip MRI in the interest of time, but you could also measure these parameters by MRI and newer techniques. The problem with the cardiac MRI is that it's actually a pretty lengthy test and requires a lot of skill, but this is improving with time, so there's a bit of promise in that field as well. This is a study that showed good sensitivity and specificity in women with MRIs. And I'm going to leave you with the unknown unknowns because, well, who knows? Thank you for your attention.